So salam alaikum everyone. And I just want to start by letting you know that I'm going to be exploring the latest advances of a variety of products as late as what it was presented at us this year, both in the field of thalassemia and sickle cell disease. And of course, this is a symposium which is funded by Vertex, and you have all the disclaimers there. So I work at St. Mary's Hospital in London. Some of you may know it because it's this place where penicillin was identified by Fleming, and that is his laboratory involved that blue plaque there, which I have to pass every morning when I go to work. That reminds me that the advances that we do today are only limited in comparison to the number of patients who have been saved by the discovery of antibiotics. Sorry, those are my disclosures if you want to have a look at them. Now, the gene therapy doesn't come on its own, but in the context of all the other approaches that we have to obtain a cure. And that involves conventional transplantation, both MATs and alternative donors. And although we don't have much time to discuss it in greater detail today, at least I can tell you, supporting what has just been said, that in the field of thalassemia, both related and unrelated matched donors have equivalent outcomes, at least during the pediatric years. And that in the field of sickle cell disease, whilst we don't have an alternative donor that appears to be better than the others, we did see at us the results of the 1507 trial following the outcomes that we already had presented as part of the Vanderbilt Learning Collaborative, indicating that haploidentical transplantation is very effective in adults, where you can obtain overall survivals of 95% and disease-free survivals in the region of 90%, which I think it is remarkable. But it is with a reduced intensity condition approach and using PTCI. Now, in addition to that, of course, we have the correction of the disease by using the different gene therapy techniques. So this is autologous correction, either by addition of functional genes with viral integration or by gene editing. And I'm particularly going to focus with the addition of a beta-like globin in the case of the Bluebird bioproduct, and the induction of fetal hemoglobin by disrupting the BCL11A enhancer, which is the product of Vertex. And I will also mention the early stages that we have of HPFH creation with the Editas product. There is the possibility of gene repair, but the use of homologous recombination is at the moment paused because it's not at a stage where it can be delivered to patients. Now, this gives you an overview of the clinical trials that have occurred, both in thalassemia. In the next slide, you will see those for sickle cell disease. And what is interesting is that they started in 2013, which is exactly the year where we created the Learning Collaborative to be able to optimize haploidentical transplantation for hemoglobinopathies. So they have gone hand to hand, and it would be nice to have a discussion later on as to how we are going to deliver these treatments, for which patient, whether there are any benefits of one or the other. But effectively, you can see that increasingly there has been both not just gene addition, but also editing of the genome, and that there are a number of different companies involved. And this is great because we're going to have increasing number of avenues to be able to cure our patients. And this is exactly the same in the case of sickle cell disease. And I'm going to pick from those the ones where there has been relatively recent data and where there is promise. So I'm going to start with gene addition with the use of lentiglobin, what is now Lobocel or Beticel, depending whether you approach thalassemia or sickle cell disease. And this is the insertion, the random insertion, but with self-inactivating viruses as safety, of a functional hemoglobin, the T87Q, which in the case of thalassemia allows you to follow its production with electrophoresis, and in the case of sickle cell disease, it has the benefit that it contains the same mutation that leads to the hemoglobin F avoidance of sickle polymerization. So the patients with sickle cell disease will get both the benefit of having a functional hemoglobin, but also the possibility of stopping the polymerization in the same way as the hemoglobin F. Now, this helps me to show you the approach to gene therapy, and no matter which product you choose, it goes in the same stages. Initially, we need to be able to collect cells that are going to be modified. That is done by apheresis, and it's not as simple as it might sound, because it has its own challenges in the cases of hemoglobinopathies. We have a hyper-expanded hemopoietic compartment, which is very inflamed, and so that reduces the quality of the stem cells. In the case of thalassemia, we can mobilize the cells with G-CSF and plerixafor. In the case of sickle cell disease, we can only use plerixafor because G-CSF will provoke crisis. And when Bluebird Bio started studying this, they have to go through a process of optimization of the product. Initially, they were using bone marrow because they were concerned about the feasibility of doing peripheral blood stem cells in sickle patients, but indeed, that did not allow the collection of sufficient stem cells for the product, and they have to move on to a refined use of mobilized peripheral blood cells with an optimized processing. And that is why there were Group A, Group B, and Group C, and many of you will be aware that Group A and Group B were suboptimal, that there wasn't good engraftment of those cells, and that allowed clonal expansion and some cases of clonal evolution, which have not occurred in the optimized product where there is good engraftment of the modified cells. So you have the collection of the hemopoietic stem cells, then the patients undergo a busulfan condition autograft, so a single myeloablative agent, and then after the infusion of the product, you have to wait for the engraftment, which, because the cells have been manipulated ex vivo, tends to be slower than you will expect with a normal autograft. But eventually you have, as you will see, a correction of the situation. So it starts with the patients with transfusion-dependent thalassemia, where we have data from both pediatric and adult patients. You can see the ranges are from 4 to 35 years of age, and we have 63 patients whose data has been disclosed. And if we focus on those who have the optimized product, so the phase 3 studies, you can see that 37 out of 41 patients, so 90% of the patients, achieve transfusion independence. And what you see on the left-hand side is the distribution according to age. And so there has been some concern, particularly because of the experience of the ticket studies, as to whether there will be a differential ability of the engraftment of the cells according to age, but actually you can see that the transfusion independent has been achieved independent of age across all of them. And this was supported further by the fact that there was improvement in quality of life. The safety of the product is consistent with the autograft that has used busulfan as a myeloablative agent. Now, in relation to sickle cell disease, it's slightly more complex, and you can see that on the graph on the right, where you have the total hemoglobin as a combination of the hemoglobin T87Q that has been transfected, that is in blue, with the other hemoglobin, which is on its majority sickle hemoglobin. And that is because the new hemoglobin that has been introduced in the genome, well, the new beta chain, has to compete with the sickle hemoglobin for the alpha chains. And so the situation you then get is one analogous to a sickle cell trait, where you can see the new hemoglobin accounts for more than 40% of the total hemoglobin as a proportion, and then the total hemoglobin that the patient achieves is normalized. On the left-hand side, you can see the red dots of the vaso-occlusive crisis that had required medical attention, whereas if you look beyond the blue bars, where the patient has already received the autograft, there's a very substantial reduction. So 30 out of 34 patients did not have any vaso-occlusive crisis during the period of analysis, which is the darker blue in the middle. And you can see that the vast majority of the patients are free of vaso-occlusive crisis. there are a number of patients who still have painful crises, and that just shows you the complexity of dealing with sickle cell disease in an adult population, where there may be other aspects like chronic pain or socioeconomic or mental health factors that can impact in the perception of pain. Now, the compound is undoubtedly safe, as you can see in the safety profile, but it's interesting to note that there are as many adverse events during the process of the apheresis as there are during the transplant process. And that just brings us to mind that to deliver safely these products, we need to have very strong and close collaborations between not just the transplant team, but between the transplant team and the doctors who look after hemoglobinopathy patients. In some centers, that may be the same kind of doctors, but often it's not. And so this has to be a team effort, because there is likelihood that once you do the apheresis or once you are in the early stages of the care of the patient, that there may be sickle-related or thalassemia-related complications. But if we focus on the group C, so these are patients with sickle cell disease, you can see that the side effects that were reported were mainly abdominal pain, anemia, nausea, vomiting, the kind of side effects that we encounter with maloblation, and that there have been no cases in the sickle cell patients, unlike in the thalassemia patients, of veno-occlusive disease. There are two patients who have long-term anemia. Both of them are, have 2 alpha gene deletions, and that is being studied further as to whether, at least with this product, the double alpha chain deletion has less efficacy in correcting the patient. And there have been 2 cases of AML reported, but I want to reinforce the fact that these were on the early product that hadn't been optimized, so it didn't lead to good engraftment of corrected cells. And this is something that we also see in reduced intensity transplantation, that if you are not able to reestablish normal hematopoiesis, there is a clonal effect pressurizing abnormal clones to then develop either MDS or AML. Now, there is an alternative approach, and that is using gene editing. And the reason why gene editing works is because we have the ability with nucleases to create cuts. And once you have created cuts, I'm sorry, yes, I thought I had gone over one of the slides, but I can go back onto that, sorry. Once you have created cuts, then those can be repaired either by homologous recombination, where there will be a complete correction of the gene, but we are not in a position to deliver this to patients. But what we can do is inactivate genes by allowing non-homologous end joining to create either deletions or insertions. And that is exactly what the gene editing technology does at the present time. So on the left-hand side, you have the BCL11A gene, which is key to move from fetal hemoglobin production to adult hemoglobin. And we all know that patients with both thalassemia and sickle cell disease don't have manifestations of the disease in the early infancy period, and that medication like hydroxychloroquine aims to increase that hemoglobin F level. And so what we do is modify the way that the BCL11A or the actual gamma globin genes themselves work in order to be in a situation where we produce hemoglobin F again. And so in the case of Exacel, the product by Vertex, what happens is that we use CRISPR-Cas technology to create indels in the erythroid enhancer, which then doesn't allow it to interact with CATA efficiently, and therefore you have reactivation of hemoglobin F. And the fact that it's in the erythroid enhancer is very important because BCL11A has other functions in the human body, like for example lymphocyte development, and this gives us the assurance that we are only going to affect it in the erythroid series. Now, there are other techniques other than the use of CRISPR-Cas, and so we can use zinc finger nucleases to achieve these effects. So what we're interested in is in the fact that we have a nuclease, in this case FOC1, which is derived from Fabrobacterium, and is directed to a specific site of interest by the zinc finger domains. And zinc fingers are groups of 30 amino acids which are joining a zinc molecule. That's the reason it's called a zinc finger, and has the ability, each one of those zinc finger domains has the ability to recognize 3 nucleotides. And so you are therefore very specific as to the area that you are targeting, because you have quite a substantial period. You have 18 nucleotides by the zinc finger, you have the spacing in between, so altogether you have 18 base pairs that you are recognizing, and you have the certainty that you're going to create a cut in the desired place. So this has been done not just in the laboratory, but we have an early trial by Sangamo, by which on the left-hand side you can see in patients with sickle cell disease we have the ability of obtaining hemoglobin F levels of approximately 45%. The last patient, the 5th patient that has been tested, did achieve 93% with the optimization of the product, and this is the BIVV003 study, which at the moment is paused awaiting further funding and development. But it does give you the possibility to see that there are other approaches other than the use of CRISPR-Cas technology. Now, CRISPR-Cas, for those of you who are not familiar with it, is the adaptive immune response of most prokaryotic cells. So we have the Cas9 protein that is able to create cuts and degrade DNA, and CRISPR that recognizes particular sequences to be able to keep bacteria free of bacteriophages. And so what we have done with the CRISPR-Cas technology is that we have created a single guide RNA by truncating and bringing together all the components of the RNA, so that it's a simple device, and that is able to recognize a particular target zone, which then the Cas9 endonuclease can cut. And so using this, we are now in a very advanced stage of the phase 2-3 trials of exa-cel, and indeed, as you know, the studies for those who are more than 12 years of age are completed, and the product has been licensed, and we are currently doing the children between the ages of 5 and 12, and we're hoping to be able to do the children between the ages of 2 and 5 later on in the year. And so the aim of the trials for sickle cell disease was to assess the number of patients who were able to be free of vaso-occlusive crisis for a period of at least 12 months. In the case of thalassemia, the primary efficacy endpoint was to be transfusion independent for at least 12 months. And so this is the data for sickle cell disease. So you can see in blue the number of vaso-occlusive crisis requiring medical attention on the left-hand side. Then you have the actual autograft procedure. There is a washout period of 60 days where we don't count it because they were still receiving transfusions. And then in the period of green is the area where we can assess the patient, knowing that if there is efficacy, it's due to the use of exa-cel. And so if we focus on the orange parts, because that has the number of patients who have been followed up for at least 16 months, so that it allows us to see whether they have been free of crisis for at least 12 months, you see that the primary endpoint was met in the vast majority of the patients. So in 28 out of 29 patients, given a 96% efficacy. Now, there are 2 patients which you will notice quickly that they have blue dots beyond the period of the transplant. One of them, the one at the top, had a parvovirus infection which led to anemia. That was a single event. The second patient is a patient that has had chronic pain and other mental health socioeconomic factors associated. And so it just leads you onto the situation where there is a great complexity once you deliver this form of treatment to patients who have established disease. But as I'm going to show you, There is efficacy across the ages, so whether in the adolescents or in the adults, we have correction of the number of vaso-occlusive crises, and most importantly, we have lack of hospitalization. So you see that the only patient that has required hospitalization after receiving the product is the one who had a parvovirus infection. So even the patient with chronic pain, at least those episodes, unlike before being treated, are not leading him to require being an inpatient in a hospital facility. Now, what that shows you on the left is the total hemoglobin obtained, and we have both data for the adults and the adolescents to show you that the efficacy is the same no matter the age. And so you have the total hemoglobin at the top, and you see how many grams per deciliter of that total hemoglobin at the bottom is due to hemoglobin F. And it represents on the right-hand side that we achieve more than 40% hemoglobin F production, so that the patient has a situation analogous to being a trait, and we know that this is a pancellular distribution of hemoglobin F. The safety shows very similar to the Bluebird Bio data, side effects that are in keeping with myeloablation with busulfan, and you can see very clearly on the right-hand side that the majority of the adverse events occurred in the first 3 months, which is what you will expect in someone who has had a transplant procedure, and then they tail off. The case of thalassemia, very similar graph, but in this case the dots indicate transfusions. And you see that if we focus on the primary efficacy set, so patients who have had sufficient follow-up so that we can determine whether they have been transfusion-free for 12 months, that was achieved in 91% of the patients, in 32 out of 35 patients. And indeed, the 3 patients who didn't achieve that primary endpoint have had a very substantial reduction in the requirement of transfusions, and today all of them are free of transfusions. It did take longer than the period of follow-up for the initial assessment, so that's the reason they hadn't met the primary endpoint of 12 months continuous, but if we wait for another year, the likelihood is that they will achieve that time point. Safety, very similar to what we have seen for sickle cell disease, with the adverse events focused in the early point and in tailing off as the transplant procedure has been completed. In relation to mortality, the Bluebird Bio product has had a death, but not related to the actual intervention, but a patient who had cardiomyopathy with pulmonary hypertension before the procedure, and that then went on to have its own natural history, and despite of the correction of the sickle cell disease, that led to his death. In the product from Vertex, there's been a death 8 months after having finalized the treatment due to COVID, potentially in a patient who had had a degree of pulmonary damage by the use of busulfan, but COVID was the actual cause of death, and there's been no fatalities during the actual period of treatment. Now, something that is incredibly important and which we often fail to look at when we do other form of treatment is the quality of life achieved in these patients. And as you can see by the multiple scores on the left-hand side of the adults, on the right-hand side of the children, this has been done very in-depth in the exa-cel trials, because we want to really understand what is the impact of this form of therapies on patients. Now, what I want you to focus on is on the bottom line, that is the minimal clinically important difference. So you have to go, you need to reach at least that point difference for it to be meaningful. I was not very familiar or experienced with quality of life questionnaires, and so I guide myself by that. So that is the minimum that you have to increase. And so you can see that if you take any of the means at any time point on the different scores, and you can see whether you look in the adults or in the pediatric patients, or in the adolescent patients, apologies, that the improvement that is being achieved is above the minimally clinically important difference. But what is more extraordinary is that the younger you are, the better the improvement it is. So you can see if we take, for example, the total score, that at month 18 you have a 9.1 improvement in the adults, and you have to have at least a 3 to 7 improvement. But if you look at the younger adolescents, you can see that the improvement is 14.1, whereas you only have to improve by 4.36. So you are improving 3 times the minimum improvement. So to me it's very important, because what this is telling us is that if you want to ensure that a patient derives the greatest benefit of this form of therapy, you ought to do this treatment at a younger age, if you want to obtain the very best result. So finally, there is a different gene edit approach to create hemoglobin F, and that is the product from Editas, in which they actual edit not the VCL11 erythroid enhancer itself, but the region of the gamma globin to create HPF8. And there are 2 studies, Ruby and Edithal, so Ruby for sickle cell disease, Edithal for thalassemia. And you can see that the design is very similar to the other studies. And they were able to present at us the very early results. You can see that the number of patients that have been treated is very small. There is only 1 patient whom in sickle cell disease has reached 18 months, and they are only in fact, in the total number of patients with thalassemia treated is only 5. So we're still at the very early stages. But you can see that the amount of hemoglobin F that is being achieved is equivalent to what I have shown you with Exasel, and that in the case of thalassemia, we're getting good total hemoglobin levels, of which the majority is hemoglobin F. And we look forward to have an update and to see what happens with this product. What is in the future? So we have the advent of base editors. So this is the ability not just to create a cut, but be able to change the nucleotide. And the earlier work that we have is by Beam Therapeutics, which is editing the genome so that the sickle mutation turns out to be something called hemoglobin Macasa, which is functional, and there are individuals worldwide with this type of hemoglobin without any clinical deleterious effects. This is at a very early stage, and what I'm showing you there is laboratory work by which creating hemoglobin Macasa, which is the blue, allows you, at least in the laboratory, the correction of the sickle cells onto a more normal phenotype, and it'll be interesting to know how this can be translated into patients. The base editing technology still is being refined so that there are no off-target effects, but it's potentially one of the things that we might see in the future. So I hope I've been able to show you that these techniques are able to deliver cure for the patients. We do have the challenge that we now need to determine better how we are going to measure what we're trying to achieve. I mean, it's easy to say that we want our patients to be cured, but what exactly do we mean by that? In transfusion-dependent thalassemia, are we talking about hemoglobin level? Are we talking about care utilization? Are we thinking about the avoidance of complications later in life? In the case of sickle cell disease, what do we mean by vaso-occlusive crisis? Do we mean that we want to abolish then not having to go to a medical facility? Are we expecting not to have any neuropathic or chronic pain? What happens to the rest of the organs that might have been damaged before you provide the therapy? For example, there was renal dysfunction or pulmonary hypertension. So these are things that, as a community, we're going to have to evaluate very carefully so that we know the true effect of the treatments that we have provided. But I do hope I have been able to show you that with gene therapy, we are able to have rapid, robust increases in total hemoglobin to normal or near normal level, that whether we use a gene addition or a gene editing approach that we're able to truly modify early stem cells, and that long follow-up is demonstrating that this is persistent in its functional curative effect, that there is a safe way to manage these patients, that the profile is consistent with having had an autograft, and that whether we do this to adults or adolescents, that we get a correction in both of them. So this gives us an opportunity to provide a one-time functional cure for our patients. And I'll be very happy to enter into a discussion.